So this is about the Be Well checklist, and it's I can explain exactly what that is, and I'll spend the presentation doing that. Just before I do that, I'll tell you about some resources that you can use. So we have a website called findresources.co.uk. And on that website, there are about 8 or 9 different syndromes. And of course, they're the syndromes we've worked with. But on there are videos, there is information, and you can search by topic. For example, self-injurious behavior or autism or aggression or whatever it might be. So you can cut across. So there's some information for you there, and we've written it in as an accessible a format as we possibly can. We also, over the years, we've worked with a different organization called Cerebra. And with them, we've written some guides for parents, and many of these will cover the individual items on the checklist. So you can see 3 there, one on pain, one on anxiety, and one on sleep. The top 3 for me, difficulties that we're not very good at dealing with. So you can download those. My research papers are all available on a website called researchgate.net, which is kind of Facebook for geeks like me. So we post our research papers on there because we have copyright over the last version before it's published. Once it's published, it's behind a publisher paywall. You have to pay to see it. And that includes the charities who funded the research have to pay to see it. That's absolutely wrong. So we post all of our papers on researchgate.net. So if you search on my name there, you'll find all of our research papers. And there you can see the Be Well checklist. And that is, that journal article is available. I sent Sarah the link, and perhaps you'd pop that, or Artie could pop that link up, because for $50 you can access the research papers. You could download and print it off if you want to, and it will give you a bit more information. It's all distilled into the checklist that you can get on the unique website, which is, and the link's there in the chat. But the original research paper's there for you. Over the years, and if you are working with any professionals, over the years we have developed assessments. How do you assess, social behaviour or behaviour in someone who cannot speak? And so we developed assessments, about 15 or 16. They're in 11 languages, and you can go to the Find Resources website. You have to create a login, but then you can download our 253-page manual, which is really brilliant bedtime reading, Move Over Grisham, and you can then just have access. And these are all free. None of our materials, and this is true for the checklist, will ever be available at cost. They are all free. And this is the last thing that we've been working on, the Be Well checklist. So it's in that research paper, but you have access for the first time ever, an accessible version that's on the unique website that you can look at. And we really need your feedback. It's only about 3 pages. There's a little survey to do afterwards, if you don't mind. I know you won't trust a researcher who says it will only take 5 minutes, but honestly, I think there's about 3 multi-choice questions and then other things. But I'd really like you to read through it if you would, and just say that bit works for me. That's not well written. I want it laid out like this, just so we can get it right, because then we'll update it and make it available, and it will be available again through the unique website. And so this is what it looks like at the moment, the actual checklist in the top left. Don't worry, I'll spend a bit of time on these, but we list the things that you have to tick off: pain and discomfort, sensory sensitivity, anxiety. We give the signs to look for, and then we say, how are these related to other items on the checklist or behavior? So it's just a way of keeping monitor of that. There are instructions on how to use it, and a way of rating these behaviors. We're great fans of keeping a little record, because sometimes you want to look back over the last year and see how you're doing. Is it all going in the right direction, or something's going better than others? So it's a real practical tool. There's the link, and it's in the chat there. You can see that. If you click on that afterwards and just zip through, I promise 10 minutes, no more. Did I say 5 minutes? 10 minutes, 10 minutes, not too long. And this is what the Be Well checklist looks like. So I'll tell you much more about the checklist in a moment and what you can use it for and what you can't use it for. But in our research over the past, or me, coming up 35 years now, my clinical work with people with severe intellectual disability, complex needs, these 9 issues are in my mind as a clinician, and I tick them off. So if someone comes to me and says, my child seems very distressed and just isn't happy, there's something wrong, or is showing a really difficult behavior, and this is roughly the list, the order that I would go through. I would ask about these 9 things. We are better at assessing some of these than others. We're getting there with nearly all of them. And in the presentation now, I'm going to tell you why these are important and a little bit about how they might be assessed. But this is the sort of, the clinical problem I might confront. So I remember showing this picture to my PhD students, and one PhD student said, he's in pain. He's got painful tummy. Another one said, no, he's anxious. He's really worried about something. And another one said, he really needs to go to the toilet. She was a mother of twins, young twins. But these were 3 researchers, 2 parents in there, who also sort of said, couldn't agree. Well, unsurprising kind of thing, but that's the problem we're confronted with. Is that sometimes it's really difficult to know, where do I start when I think someone's in distress, when their behaviour's changed and I know something's up. The same is true for difficult behaviours like self-injury and aggression. And this graph, I'm sorry for showing graphs and tables, it's just the way I do things, but it shows you across a number of different syndromes that are listed along the bottom. For example, Angelman's, Credit-Shack, Cornelia-de-Lange, Fragile X, Prader-Willi, Lowe, and Smith-Magenis. It shows you that the rate of self-injury varies across those syndromes, and so does aggression. So some of these are associated with syndromes. That doesn't mean they can't be changed and they're inevitable, the absolute opposite of that. But we need to know why in those syndromes they're more common than others. But again, if I'm, if I see a child showing self-injury, headbanging, for example, I need to go through my checklist to make sure I don't miss anything. The main thing I would say, and this is our T-shirt slogan at work, it doesn't have to be like this. When there is distress and there is difficult behavior, it doesn't have to be like this. For most people, most of the time, we can make a significant change in well-being and behavior. I firmly believe that. It's just, and it's interesting, it's not about trying to come up with new treatments or interventions. It's about getting the right intervention for the right person for the right reason. And that's what the checklist is going to help us do. I don't know if you've seen this book. It's Atul Gawande, and he was a heart surgeon, and he looked at heart surgery outcome data. And these heart surgeons are kind of incredibly skilled people. But what he found is they occasionally make mistakes, the most sort of simple mistakes. And he introduced a checklist of, when you're doing surgery, before and after, you run through this list and you tick them off. And the survival rate went up by 20%. So it wasn't any massive, breakthrough in how the muscles of the heart work. What it was about make sure you don't miss things and tick things off. And that's what we're trying to do. So the items in our checklist, our Be Well checklist, that each of these can influence behavior and well-being. They can be changed, but they're often missed or neglected. They also help us reduce diagnostic overshadowing. And you may have come across this, but may not know, and that's what it's called. But on the right there, this was when we were studying pain. A parent sent me this email about their child. I actually had Angelman syndrome, and said, my child only has this challenging behavior, change in personality, ripping lumps of hair out. We are not believed at the hospital. And actually that child did have reflux. This is caused by acid coming up from the stomach into the esophagus, burns terribly. very painful. And it's the last bit there in red that I want you to see, where someone was saying, well, it's behavioral or neurological. What I think they meant by that is, look, it's just part of Angelman syndrome. It's just part of autism. It's just part of intellectual disability. That's not right. That is diagnostic overshadowing, where you say, well, you've got this diagnosis of autism, of this syndrome, of this genetic change, or whatever it might be, and that's what causes the behavior. And that's not right. And we have to guard against diagnostic overshadowing. When we put our checklist forward of these items, we do not intend to replace other diagnoses, for example, autism or ADHD. My advice on those is always, if you have those diagnoses and they work for you, they help for you, great, take it. If they don't, don't. There's nothing kind of necessarily beneficial or detrimental about having a diagnosis. Does it work for you? If it does, take it. If it doesn't, don't. But we are neutral on the value of that diagnosis. I say it rarely tells us exactly what to focus on, exactly what to do. That should be a bit more needs-based. Each of our items is evidence-based. So we have published at least one paper that shows this association in one particular syndrome, and then we try and generalize across. So and we deliberately focus on person characteristics. This is important. We are not looking at the environment, and that can often be very influential on, well-being and behavior. I know that, and we often emphasize that, but we mustn't miss these person characteristics. So doesn't cover everything, but it does cover the person things. So when do you use it? This is where we want to, what I felt was important was about empowering parents, empowering them to ask for the right things and identify the things that might give you more bang for your buck, as it like, that, the things that are going to be useful and make a change for people. So also, I really wanted, I felt it was very important to have something where a parent and a carer might be with a professional and then have a discussion about which items or which things we're going to look at. What do we prioritize? What do we save for later? What's the main thing we're going to go after? How do we do it? Let's get a plan. Let's get some priorities. We'll share those and we'll move ahead. So it's kind of very collaborative. It's not, a professional telling a parent, this is what we're going to do, or the other way around. It's collaborative. It's working it out together. So you can use it when there's concern about behavior or well-being, when you're thinking about the future, and during regular reviews. So it doesn't necessarily have to be a concern, someone's distressed or showing difficult behavior. It could be the annual review if you have those, or 3 monthly or termly reviews, whatever it might be. Let's just run our eye down these. Is everything doing as well as it could? So just before the checklist, these things aren't covered and are really important, or two of them. Seizures. So I'm not a neurologist. I don't know anything about seizures apart from the very, very basics. So I would always say that we know so little about atypical presentation of seizures in people that it should be checked out. We at least need to have a discussion about whether that's a possibility when there's a change in well-being or behavior. Keep medication under review. Again, I am neutral on the use of medication. I feel that we should be targeting something very specific with medication, and we should evaluate, is it helping, or are there unpleasant side effects? And if it's not working, when are we going to stop it? Not when are we, just let it continue. So that seems to be very important. So for medication use, I'd always ask the question, what's the evidence that this is helpful? Are we monitoring both good outcomes and undesirable outcomes? How frequently will we review it? And what will we do if it's not working or if it is working? And then the final thing you do on the checklist is you rate the behavior and well-being, and there are instructions on how to do this. So this gives us a baseline. So what we say is, okay, this is the behavior I want to change. And at the moment, I'm going to give it a rating of 5 or 4, depending on how frequent it is. And the response I make to it, I'm going to rate that as well. And then I'm going to rate the child's well-being. Now, the point of doing this is you can look over time and see if that's changing. And if it's not, then we're not quite getting something right. So it gives you a way of looking at that. Then you work through your checklist items and rate them. And that's all the kind of technical stuff, if you like. These are the items on the checklist. And I'm just going now to tell you why these are important. I think pain and discomfort in people with severe intellectual disability complex needs who have impaired communication is the most missed cause of difficult behaviour and poor well-being. We miss it. And if you think about the number of conditions that any child might have, any typically developing child, and there are some that immediately spring to mind: toothache, earache, really common changes in behaviour. Now, if you look at typically developing children, then about 1 in or 15% will bang their head between the ages of 1 and 4. So we see this in typically developing children. Half of those children will have a middle ear infection. And that's really important. Also, this is a study of children with Cornelia de Lange syndrome. Now, I mention this because in that syndrome, a lot of the children, we think 90 to 95%, experience reflux. I think this is incredibly common in people with neurodevelopmental disorders. Loads of research coming out on this, and it is missed repeatedly. And frustratingly, it's not that difficult. I'm not a medic, by the way, but it's not. You know, medications like omeprazole, proton pump inhibitors, and you have surgical intervention like fundoplication can be done. On the right there, that graph shows you that the people with CDLS showing Cornelia de Lange, who were showing self-injury, had much higher scores on a measure that we developed of reflux, behavioural signs of reflux. It was things like scratching round here, scratching behind the ear, teeth grinding, especially at night, having a wet pillow in the morning, so increased salivation, very bad breath, for example, and a number of other signs. But also, reflux causes middle ear infections, even in typically developing children, because the acid gets up the eustachian tube. It can also get into the sinuses, so you get sinus problems, and the acid erodes the enamel on the teeth, so you get tooth decay. It's a perfect storm. So children end up with a number of different painful conditions, and we have shown time and time again in Cornelia de Lange, now in Cri du Chat, and we have just shown it in autism, that reflux is a primary cause of self-injurious behaviour. It's really worth thinking about and checking it out. What have you got to lose? Why might pain cause self-injury? Well, this technical diagram shows you there are two kind of signals going up to the brain. So you have these chronic or sharp pain goes up the C fibers and A delta fibers. But if you stimulate an A beta fiber, and you can do this by rubbing where the injury is, you can block the pain. It's why your mum told you to rub it better. It doesn't push the pain away. It stimulates a different fiber, and that blocks the pain. And two important things about this. One is that, of course, if you rub too hard or you slap too hard to stop another pain, you start to create another injury. And then you go around in a circle. The other thing is, we've seen a lot of people experiencing reflux, pain in the throat, chest, who pull their hair in response to the reflux. It gates or blocks the pain. Take home clinical message: the site of the self-injury is not necessarily where the pain is. It could be somewhere else. That's important. If you go to the Cerebra website, you can get a pain scale. This is called the FLAC. It's a little measure developed by Lynn Brew, very kindly just turned over copyright to allow Cerebra to develop this. We've been using it in a number of research studies, and basically you're looking at face, legs, activity, crying, consolability. Face, legs, activity, crying, consolability. Those are 5 signs of pain in non-verbal children. Different children will have different profiles, but this is a way of keeping a baseline record. So you can download that from the Cerebra website, pin it up on the wall, and it's a very good baseline. The other bit of advice I would give you to avoid that diagnostic overshadowing is have a little bit of video of your child or the person you care for when they are well, when they are content. And then have 3 30-second clips of video when they are showing the behaviors you are worried about. The reason for this is someone says, oh, that's all to do with that syndrome. You can say, no, this is when he is well. This is when he is not well. There is a change, so there's a reason for it. Clinicians like me find it incredibly helpful to see some of the behaviors you're talking about. Otherwise, you're going to go 9 times out of 10 to see the specialist, talk about this behavior, and your child sits there absolutely good as gold doing absolutely diddly squat. And so nobody gets to see the behavior. So it's really important that people can see this, can see facial expression, the totality of the change. Good, useful thing to do, I think. Another very, very underestimated course. We hear more about this in autism now, that sensory sensitivity, it's now even in the diagnostic criteria more than it's ever been. As we have looked across the syndromes, we almost always see it. We almost always see it. And the profiles will differ. But sensitivity to sound, touch, light, smell, taste are really important, and they can be triggers for poor well-being or behavior, and I'll show you how in a second. But I think this is really important. We have to get better at this. There are some good measures out there, but we do have to get better at it. This measure we've used, Sensory Profile 2 by Winnie Dunn. There are others, and there are more coming out now, but it does help us to manage some of the sensory sensitivities. And that picture there shows you some of the ways in which you can do that. People wearing ear defenders, and you may know, cutting labels out of clothing, comparing one kind of type of clothing material to another. There are lots of ways in which you can work through this to work out what children might be sensitive to. Again, anxiety. I don't know if you've followed the story in autism, but the levels of anxiety, we're slowly realizing that these are very, very high. If you look on the left there, I've just listed some of the characteristics of anxiety that if I was a clinician meeting someone of typical development, I'd ask about, are you feeling worried? Are you tired? What's your concentration like? How are you sleeping? And what's your overall mood like? I can do none of those things when someone has a severe intellectual disability and poor expressive communication. So I have to look for behavior, and that's when we can get it wrong. Remember my 3 PhD students talking about that little boy. And in the body, you'll know this when you once did an exam or took your driving test or whatever it may be. Heartbeat, sweating, dry mouth, muscle tension, trembling, and so on. We may not necessarily see these. We may not necessarily see these because the autonomic nervous system might not be functioning in a typical way. So it comes down to behavior, and the behaviors we see most frequently related to anxiety are avoidance or escape, not wanting to go into situations or wanting to come out of them, or showing difficult behavior in some of those situations. Quite hard to pin down. The autism websites are starting to have really good information on this, but if you look at the bottom of this slide, fight and flight, you'll know that. That's what adrenaline and anxiety does to you. But don't forget freeze. And we do see this a lot in people where someone is anxious and they simply absolutely freeze, rooted to the spot. Don't show difficult behavior. And it's kind of hard then to work out what the problem is. Here's some numbers. In typically developing people, about 3 in 100 will experience anxiety. If you have an intellectual disability, the numbers go up to 20 in 100. Autism, 40 in 100. Rare genetic syndromes, in this case, Fragile X, Williams, Cornelia-de-Lange, 80 in 100. In some of our research, people are, 80% are clearing the diagnostic criteria. I'm not saying that's true for all syndromes, of course, and actually, if you look across syndromes, you see different types of anxiety. In Williams, you see loads and loads of phobias. In Fragile X, you see intolerance of uncertainty, which I'll come to in a second. But I think this is a salutary lesson. Right up there with pain, we have to think a bit more about anxiety. 2 reasons for anxiety in people. This comes from the autism literature, true in typical development. One is intolerance of uncertainty. If I do not know what's going to happen, if something's going to be unpredictable, if something's new, if it's not like it was before, that can evoke anxiety. Very much an autistic kind of characteristic, if you like. But this intolerance of uncertainty is becoming the main explanation for anxiety. The second reason is the development of phobias. And this is really, I'll give you an example of a little boy I met. And when he was going into the the dining room at school, he used to self-injure and he wouldn't go in. And people thought, well, we sit him down quickly and then we give him something to eat. And so they thought, well, perhaps we're rewarding him for self-injuring with the food. Now for him, the problem was a different one. So what had happened was he has sensory sensitivity to noise. And if you cast your mind back or go into the school kitchen just off the dining room, it's all stainless steel and it's all banging and clattering and the acoustics in there are awful. And what would happen was he was hypersensitive to noise. He'd approach and he'd remember the last time I was there was that awful noise. I just want to get out of it. If I self-injure, I can get out quickly. And it wasn't the food that was rewarding. It was actually the quick escape from the dining room. And trying to see it through that little boy's eyes of how he was experiencing the room. And you can see, and this is the typical classical conditioning model, that in the middle, the kitchen became associated with the noise. And actually, you could walk by the kitchen at a non-meal time and he would self-injure. And it was nothing to do with the food at all. It's just the fact that he was near the kitchen now was enough to make him self-injure, to be moved away from it quickly. So the important thing about that is you can't see what the trigger is, if you know what I mean. We can see it's a kitchen, but you might be misled. Sensory sensitivity, very, very important. The Autistica website is a good place to go. We're working on that project now. It's run at Aston University, which is also in Birmingham in the UK. And you can go onto the website at Autistica, find that anxiety and depression in autistic people who speak few or no words. And at the bottom, there's a reference. Anything written by Jackie Rogers, RODGERS, at Newcastle University is well worth reading. If you go on to Newcastle University, track Professor Jackie Rogers down, and she has posted on there some materials, how do I manage uncertainty and so on. It's a really good resource. She's a really outstanding clinician as well as a researcher. Sleep, now I don't need to tell you about this. Everyone's sitting there drinking coffee and yawning, but it's kind of, again, it's almost often said, well, people with learning disabilities sleep less than other people. Why? There's actually no reason for that at all. There is no reason whatsoever that someone should sleep less because they have an intellectual disability. The amount of sleep should be the same. Remember that if you've ever seen the, it changes with age, of course, but the variability in the population is absolutely huge. So it isn't necessarily true that if you don't sleep a lot, that there's a problem. What is a problem, I think, is when you're getting up and what's happening after that. So if there is a sleep problem, first of all, don't just think, well, it's because of this, that, or the other. You can address it. And the reasons might be pain, anxiety, or learned behaviors. Now, one other reason is a sleep apnea. So if you have met anyone who has Down syndrome, often people have a sleep apnea. And what that means, often in Down syndrome, the tongue is blocking, and the low muscle tone in the throat means that this airway here becomes obstructed and people stop breathing, basically. It's not dangerous. It just stops breathing momentarily, and then you wake up. It characteristically, you get what we call a snore snort. So you get a snore, then a wake up, and that might tell you there's an apnea. Now that might seem, you know, not particularly problematic, but it changes the whole structure of sleep because you don't get from REM down into deep sleep, if you like. And a really interesting study in children with Down syndrome showed that if you monitor the children the night before, you might monitor their oxygen levels, because oxygen drops down when you've got an apnea because you're not getting all the air in. Test those children the next day, low oxygen at night, much more impulsive the next day, couldn't control their behavior as much. Really interesting. So we've no reason to think that doesn't exist in all of the children we see. So sleep problem of itself is, I think, a quality of life issue. I think we'd all agree on that, but it does affect our daytime behavior. So it's worth a go. It's worth a go. The research we've been doing on this, just some of the assessments, but actually it's quite good to have a, you know, a really objective record of the sleep. There are some of these, this is the most common questionnaire that's used. We use these things, they're called actigraphs. So it's a bit like a Fitbit. Other outrageously expensive things are also available, but you can get these now and they're pretty accurate. And if the children will wear them, we've sewn them on the back of the children's gym jams. We put them on ankles and so on, so that we know how much they're moving at night. And then we have a record, and this is really good to drop in a, you know, a bit of a pile on the consultant's desk, you know, and say, look, you know, 3 hours of sleep a night is about all he's getting, and he's sleeping in the afternoon, so it's all getting out of phase, and it's all good. But it's good objective record. Bottom right, we've also used video, nighttime video. And one of the studies we showed, it's this one down the bottom about Angelman syndrome. This really surprised us. In Angelman syndrome, as children get into early adolescence, they often experience a scoliosis. So as the spine curves a little bit, it puts pressure on the stomach, and guess what you get? Reflux. And what we found is the children at night were kicking their legs a lot. Remember the flat face, legs, activity, legs. And they were kicking their legs just before they woke. So what we think was happening was the reflux was worse at night. True in Cornelia de Lange as well, because you haven't got gravity to help keep all the stomach contents down when you're lying prone. You experience the pain, it wakes you up. And if you do experience reflux at night, you'll often aspirate, in other words, breathe in, take a bit in, and then the children wake coughing very, very abruptly, and you know, something akin to an apnea. So really important to keep an eye on this and try and get some objective records. Sleep problems for me are the classic, it doesn't have to be like this. It doesn't have to be like this. Emotional regulation, I think we've been very unwilling to talk about the emotions of people with more severe disability. This shows you two different syndromes. I'm just showing you here how people with different syndromes respond with different emotions to exactly the same trigger. So 80%, if you look on the left, repetitive questioning is shown by about 75% people with Fragile X, 75% people with Prader-Willi. Same behavior, repetitive questioning. And that's what happens when you disrupt their routine. 75% will ask loads and loads of questions. You know this probably. In Prader-Willi syndrome, about 75% then show anger and a temper outburst. Very, very common, really uncontrollable temper outburst. In in Fragile X, it's completely different. People respond with anxiety. So the point I'm making there, you get the same response to disruption to routine, repetitive questioning, but the emotion people feel differs between those two syndromes. And we think that emotional outbursts, I think is the term people prefer to use now, I think they're really underestimated. And they're often thought about as learned behaviors, but I don't think they are learned in the same way as some other behaviors are. It's an overwhelming emotion. I went down to New Zealand. Someone had to go down and give a talk at the conference. I volunteered to pop down. And I'm really pleased that Frankie Thornton, a young woman with Prader-Willi syndrome, described her poster to me in the research session. And she was describing what happens to her when she experiences a temper or emotional outburst. And you can see it there. It kind of speaks for itself. But what always stuck with me was that she said, she didn't say, this is what I do. She said, this is what happens to me. And that really stuck with me because it meant that she felt that this was something she had no control over. It overcame her and she couldn't control that emotion at that time. And we've been working on this problem, or Tony Holland's led some wonderful research at Cambridge University, where he's been stimulating the vagus nerve that you can do around the neck. And for some people with Prader-Willi, this reduced their temper outbursts very significantly. So there was no other intervention, no behavioral intervention. And there's some wonderful video of people with Prader-Willi talking about this, talking about how it changed their temper outbursts and their experience. We interviewed people, parents and carers of people with Prader-Willi. Look along the bottom here. We interviewed people about their temper outbursts. You can see how long they were lasting, but look at the final thing that happened. Apology, 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 self-deprecatory speech. I shouldn't have done that. I was wrong. Apology, apology. Now that really suggests to me that people were not able to control their behavior at that time. So we have to start to think that not all behavior is learned and that some of these behaviors are around, it's like an emotional supersensitivity, if you like. The threshold for a trigger into an outburst is less. We looked at this in another syndrome. So often in Prader-Willi, this would happen in response to disruption to routine. In Lowe syndrome, it happens for a different reason. So we see lots and lots of emotional outbursts, and wonderful researcher, Jane Waite, sat down with the children and did the Teddy task in the top right-hand corner. What's the Teddy task? Well, you say to the children, look, the teddies are coming up towards you, and you can either wait quite a long while, and Teddy has 2 balloons, and that will be double the size of fireworks on the screen. Or when Teddy with 1 balloon comes, you can pick him and we'll just have half the fireworks. Now, it's, can you wait for things? Can you wait? The children with Lowe syndrome, they found it really tricky and they would always choose Teddy with 1 balloon. But what was really interesting was when you measured the number of seconds they would wait for, it predicted perfectly, almost, how many outbursts they had during the day. So in other words, those children who found it more difficult to wait had more outbursts in the day. This tells us again that it's something in the child's difference. We think it's a difference in their cognitive profile that's driving this, that really underpins this. Here's Jane again. And what she was trying to do now, this is another checklist item. It's about, we call it cognitive difference, but you'll see in the checklist, it's about adherence to routine and can't wait, or impulsivity. Those are the 2 critical things. This is about whether you can wait. And again, she was doing a little task. You can see she's got a thing about bears when she was doing this one as well. This is for children with Rubinstein-Taybi syndrome. And she's got the good bear and she's got the naughty dragon. Now, what you have to do is do what the good bear says, but you must not do what the naughty dragon says. So with children with Rubinstein-Taybi, they've got to do what the good bear says, and it's stereotyping of dragons, really, that you should not do what the naughty dragon says. And what she found is that children with Rubinstein-Taybi, they could not stop themselves doing what the naughty dragon said. And there's some lovely video where they would do it and they say, oh no, I shouldn't have done that. And so they couldn't quite stop themselves. But again, the correlation was the children who found it more difficult to stop themselves would ask more questions, more repetitive questioning throughout the day. And that told us again a link between their cognitive profile and their behavior in the day. And this is a slightly different model, so stay with me on this one, but this is about, can you change how you think about something? So look at the red truck, blue star, red star, blue truck. And we said to the children, this is children with Cornelia de Lange, I want you to match the red things. So match the red star with the red truck and match the blue truck with the blue star. You're matching on the basis of color. And when we asked children with Cornelia de Lange to do that and children with Down syndrome, they were both as good, no difference. But afterwards we said, okay, I want you to change now. I'm going to give you a different rule. I want you now to match by shape. So match star with star and truck with truck. And when we asked the children with Cornelia de Lange to do that, they now found it much more difficult. They found it really hard to do. The children with Down syndrome just changed in the rule. But because we'd established a rule, this now meant the children with Cornelia de Lange could not shift. And that is also true in people with Prader-Willi. Forgive this really awful slide. But basically we found the same thing in people with Prader-Willi. When we asked them to switch from color to shape, they were slower than typically developing children, but guess what? It predicted how adherent to routine they were, how much they stuck with routine. And that was really, really important. So in other words, when people are sticking to routine, it's not about being stubborn or obstinate. It's about finding it really difficult to do something differently. And when we looked, we used something called fMRI, looked at the brain activity of typically developing children, children with Prader-Willi. And on the screen, if you look in bottom left, typical development, you see that red area there around the middle, that lighting up. In the Prader-Willi group, it does not. And that bit of the brain is the bit of the brain responsible for switching, helping you move from one thing to another. And this was really important to us because what it showed us was that this is nothing to do with stubbornness. If you read descriptions of people with Prader-Willi, people you say very obstinate and stubborn, very value-laden comments about people. This showed us it's not about won't do, it's about can't do. This is much, much more difficult. And the parts of the brain that should be working overtime at that time are not. It's different. Okay, so on our checklist, we're now down to social differences. And there are two that I would mention. One is autism. But I think it's important to say that the presentation of autism is often very different in the syndrome. So here, look at the Cornelia de Lange group, about 50% would get a diagnosis of autism, 75% would get a diagnosis of autism spectrum disorder. Now, we asked the children with Cornelia de Lange to look at pictures of faces, and then we can see where they're looking using something called eye tracking. And the red bit is a hotspot. It's where the children look. We don't tell them where to look. We just show them the image and then they look. People with autism do not look at the eyes when you do this task. They'll be looking pretty much evenly around the face. They'll often look at bits of detail, for example, around the ears or somewhere like that, but you don't get a red hotspot. But even though we've got very high levels of autism in people with Cornelia de Lange, they are still looking at the eyes. So what this tells us is that the profile of autism is very different in the syndromes. And as I mentioned before, if the diagnosis is helpful, take it. If it's not, don't. It differs a great deal. It can be a real problem because if it's helpful to have the diagnosis, some of these children get missed out inappropriately, I think. And just one more difference. This is about social anxiety. So in some syndromes, we know this is very common. So in selective mutism is where you speak in one environment, but not another. You'll speak to some people, but not another. It's very common. You can see there about 1 in 5 people with autism. Again, slightly less in Fragile X. In people with Down syndrome, it's quite uncommon, less than 1 in 10. 4 out of 10 people with Cornelia-de-Lange evidence selective mutism speak in one environment than not another. And they show incredibly high levels of social anxiety. I know I mentioned anxiety before. I think this is a really special case. And it's not, what's interesting about it is it's not an unwillingness to engage with people. Because people with Cornelia-de-Lange maintain very, very good eye contact. They're often smiling during an interaction. And interestingly, they gesture at twice the rate of someone of typical development. So they are clearly wanting to communicate, but they find that situation, particularly with unfamiliar people, incredibly anxiety provoking. At the other end of the spectrum, and this is true, say, Williams syndrome, Angelman syndrome, Smith-Magenis, we find very, very high levels of social drive to be with other people. This is a particular, I'm sorry it's so fussy, but it just reminded me to make the point that in Angelman syndrome, unfamiliar people make lots of social approaches, also true in Williams syndrome and Rubinstein-Tavy syndrome. In Smith-Magenis syndrome, it's highly specific. So you have an incredibly strong attachment to one person, usually the caregiver, but it can vary with environments. So it will be one person in school and then one person at home. But the strong attachment to that person can be a real problem. It can trigger, again, in Smith-Magenis, we see very high levels of emotional outbursts. And if people cannot be with the person they want to, it can trigger quite high levels of emotional outbursts. So it's worth, again, just on the checklist, thinking about that. This is the wisdom of Elvis Presley. I thought this statement must have been made by a philosopher. It turned out to be Elvis Presley. But all of those things I've just told you, those 7 things, they tell me that people experience the world differently than other people. And that feels like I might be marginalizing people and emphasizing difference. But we can't improve inclusion unless we know how to do that. We've got to, specifically be able to do things. Audio loops work for people with hearing impairments because we knew what to do. Ramps work for wheelchair use because we knew what to do. So all of these things, I think, are a different way that people experience the world. And we have to stop judging and saying you're obstinate or you're kind of impatient. You're constantly having these awful temper outbursts. Control your temper. We have to try and see it from the person's point of view. We have to walk a mile in that person's shoes. So I mentioned the person characteristics. Excuse me. I'll just say something about learned behaviors. This is the most common cause, but nearly everything I've said affects this. But this is a really simple example where, top left, someone might have a need for something. They show self-injury, bang their heads. We find it really unpleasant and aversive. Of course we do. It concerns us. We're frustrated, anxious, confused, distressed if we see someone bang their heads. It makes us act. When we act, we might disengage with the person. We stop doing something in order to comfort them, reprimand them, offer, restrain. And when we do that, that was need for others to stop something. We remove the thing. So if I'm asking someone to do a task and they don't want to do it, they may show self-injury. I momentarily stop presenting the task in order to comfort them and protect them from more self-injury. When I do that, they have learned that self-injury leads to the task going away. So the next time I want you to take that task away, I will self-injure. You'll find it unpleasant. You will comfort me. And when you do that, you're stopping asking me to do the task. You could do this for attention as well. And it's really important to think about how we feel when this is happening. So if I see self-injury, it's aversive and I act. This time I'm engaging. So this might be attention driven. and that presents a reward, so the person finds that rewarding. But now the challenging behavior or the self-injury stops, and that's a reward for me. When that stops, it's so rewarding. So the next time I'm in that situation, I'll do the same thing because it worked last time. But because I do the same thing, I reward the behavior. But then when the behavior stops, it rewards me. Nobody's doing this on purpose. Nobody's doing this on purpose intentionally. It's our natural response when we see someone hurting themselves, hurting someone else, being aggressive to a sibling, doing something in a supermarket that's embarrassing, difficult for everyone, and so on. We've all been there. It's a kind of natural response. But the main point is we need to look at this learned function. But at the same time, if I'm asking you to do something and you are tired from a sleep disorder, it makes it worse. If you are impulsive and cannot wait for the thing, that will trigger a learned behavior. If you are sensory sensitive, the little boy going into the kitchen, he learned that self-injury removed that sensation. So the learning bit is key, but it is affected by everything else that I've mentioned. And we're just trying to make that learning bit a bit better. Number 9 on our checklist, the final thing. You can see that I've run horribly over time. The last one on our checklist is communication, and we all know this. But we have said in the checklist, there are, I think it's about 8 or 9 very basic things that everyone should be able to reliably say or have heard. I'm not saying we shouldn't go beyond that. People should communicate because it's a lovely thing to do. But these basic things are the bottom line. We really do have to be able to do these things. And I know of no evidence whatsoever that no matter what someone's level of disability, everybody can learn these 8 or 9 basic things. There's no doubt about it. So I've mentioned this, but the checklist items all are related to each other. And that's why you have to work through the checklist, get your priorities. If someone's got poor sleep, they're going to be more impulsive. If someone's in pain, they won't sleep. They're going to be more impulsive. If someone's got anxiety, poor sleep, impulsive, learned behavior. Anxiety, sensory sensitivity, showed you the example, and so on. These all hang together, and I think that's what we mean by complex needs, but we've got to work through them in a simple way. This is on the back of our t-shirt. I said on the front is, it doesn't have to be like this. Please take that message home with you. This is on the back of our t-shirt. It was always about focusing on the things that we can change and knowing which of those we ought to go after. So I'm going to stop there. Sorry, I've gone on a bit too long as usual. Just finished by showing you, this is a group of PhD students, postdocs, research group. Kind of absolutely incredible, because whenever I say I did this research or we did it, what I really mean is they did it. And I managed to sort of go to the conference in New Zealand and tell everyone about it while they slaved away at home. They're absolutely wonderful group of people, super bright, super hardworking, but absolutely dedicated to improving the well-being of people with severe disabilities. So I'll stop there.